Hello and welcome to this social media event uh, on navigating the complexities of cutoff values for non-invasive tests in the diagnosis of fibrosis in patients with MASH. This is a recap of a recent webinar that was hosted by Medscape Education, uh, and I'm joined today by the faculty of this program, Professor Quentin Anstee from the University of Newcastle in UK, and Professor Richard Sterling, who is my colleague and a professor of medicine right here at Virginia Commonwealth University Health Systems. So during the program, we covered a lot of ground and specifically talked about the importance of sensitivity and specificities of various non-invasive tests and the general approach towards evaluation of patients with suspected NASH. We covered the AASLD practice guidelines and honed in on the target population of individuals who had metabolic risk factors such as type 2 diabetes, prediabetes, and or two or more metabolic risk factors, or those with imaging evidence of hepatic steatosis. And we wanted to start with using an instrument called the FIB4, which is calculated from the patient's age, serum AST, ALT, and the platelet count as a starting point, followed by further risk stratification. Uh, so maybe this is a good point over time to really ask Professor Sterling what the FIB4 is and what was it designed to do. And then maybe Quentin, you can tell us a little bit about your experience with how to on the use of FIB4 in your clinics.
Sure. Thanks, Arun. So the FIB4 was originally developed in 2005 and published in Hepatology in 2006. And the main goal at that time was to develop a non-invasive way to assess for those with advanced fibrosis, which would be bridging fibrosis or cirrhosis, or the F3 to F4. And it was done in a cohort of close to 800 patients with HIV and hepatitis C. And at that time, one of the few other biomarker or panels that were available was something called the AST to platelet ratio index. But the FIB4 was developed a little bit differently, and it turned out to work out pretty well to differentiate those with advanced fibrosis from those that didn't. And it subsequently was confirmed and validated in other large cohorts of patients who had undergone liver biopsy with hepatitis C. And since then, it has been modified slightly as far as the thresholds in patients with metabolic dysfunction-associated steatotic liver disease, or MASLD, with slightly different thresholds because it's a different disease, but it's been validated as an excellent initial biomarker, particularly given it has excellent negative predictive value and specificity on the low side to rule out those who don't have any significant liver disease and allows you to identify those who might have more significant liver disease, which then would require the further testing.
Okay, so it's widely available, uses very simple tools that everybody has available to them, and can be used mainly to rule out advanced fibrosis. So Quentin, you have a lot of experience now using the FIB4. Can you speak to that and your experience?
Yeah, absolutely, Arun. I mean, I think one of the really important points here is that whether you're in the United States following the AASLD guidelines or in Europe following the EASL guidelines, there's a great deal of similarity between them. And the starting point in both is to use the FIB4 to calculate that as Richard has explained, and then to look at a cutoff of 1.3. And that's the number to have in your head. If the value is below that, you have a very high negative predictive value, and so it's very useful for ruling out patients. Above that level, as the guidelines suggest, you probably need to go on to a second line test, and I know we'll come back to that in a minute.
Yeah.
There are a couple of things about FIB4 that I think it's worth highlighting. So the first is that the performance of the test degrades once individuals are over the age of 65. And I have to say, in our practice, we found this out by accident. We placed the FIB4 into our community guidelines for our primary care physicians, and we found ourselves being inundated with referrals from people in their late 80s and 90s. Based on the FIB4. So one of the things we then went off and did was to recalculate what an optimum threshold might be to maintain that negative predictive value and that balance between sensitivity and specificity. And what it looks like is that 1.3 is the right threshold if you're aged between 35 and 65. But once you're over the age of 65, you probably need to push that threshold up a bit. We settled on a value of 2, but you know, there are still, I think, a lot of work going on in that area to pin that down. But a very useful first-line test, Arun.
Yeah, thank you. Thank you. So, well, I think there may be a couple of other caveats to this. One, of course, is that this is not to be measured when someone is acutely ill in the hospital. That because the liver enzymes can often be elevated when you're hospitalized for a variety of reasons and does not provide a true reflection of the baseline status of the patient. But then maybe, Richard, you can maybe also tell a little bit about alcohol, that this is really rather MASH specific because this cannot be translated easily into those who are also consuming substantial amounts of alcohol and or have type 2 diabetes. And with the performance, again, there are some issues in those with type 2 diabetes, which is why we need maybe secondary testing for those with a FIB4 over 1.3.
Sure. So again, when this test was developed, I think the average age of the cohort was in their 40s, and so it was never really meant for the people that were young. So it's not going to really work well for children, and probably doesn't work well for people under the age of 30 as well. And as Quentin mentioned, older individuals, we didn't really have any that were in that trial that were older, so that didn't come up. So other things, again, that would affect the index would be anything that causes the AST to be greater than the ALT that's not reflective of that AST to ALT flip that we see in people with cirrhosis. So that would include things like alcohol or anyone with myositis or muscle damage or anything like that, hemolysis. Also, anything that might affect the platelet count to be either artificially high, such as someone with a splenectomy, or artificially low, for example, someone who has ITP or some other reason to have low platelets that doesn't reflect liver fibrosis at all. And all these points that you need to take into account when interpreting are detailed in the recent AASLD guidelines on the use of non-invasive liver disease assessments that were recently published. So there's a really nice table in there that you can refer to.
Yeah, thank you. Thank you, Richard. I think that's really important. But this brings us to the important issue of what do you do when the FIB4 is above 1.3? And, we said it has very good negative predictive value. So in populations where the prevalence of advanced fibrosis is relatively low, such as in primary care, this can be used quite effectively as a negative screening tool. It is also linked to clinical outcomes, and essentially these are the same individuals who do not have liver-related outcomes in the immediate 4 to 5 year future. But when you go above 1.3, there are a couple of zones. One where you are relatively confident that someone has advanced fibrosis, and another one which is sort of an intermediate zone. It used to be called the indeterminate zone, but that's when we were relating all of this to fibrosis. But we do now also have data linking this to clinical outcomes. So maybe Quentin, you can speak a little bit to that. And in your practice, what are the tests you're currently using for secondary testing to gain more certainty as to whether someone indeed has enough liver disease to warrant either triage to a gastroenterologist or hepatologist, or for consideration for treatment?
Yeah, no, thanks, Arun. I think there are a couple of important points there. So we were very keen to try to understand whether FIB4 can actually predict long-term outcomes. So what we did was we looked in what's called the CPRD database. That's a very large primary care database. It's got somewhere between 20 and 40,000 individuals in it from across the United Kingdom. And what we found is that if you take the standard 1.3 threshold and then the high end threshold, which is usually 2.67, you can develop, exactly as you've said, a low risk, an intermediate risk, and a high risk bracket. Below 1.3, in between, and above 2.67. And what we found was that the outcomes in terms of long term, both for liver related events and death, or indeed for cardiovascular deaths, quite interestingly, tracked with which of those brackets you were in. So that's prognostic value. The additional thing we found was that if we repeated the FIB4 score 12 months later, we could retune that prognostication further. So if you were high at the first one and still high at the second one, you marked yourself out as being in the worst prognostic group. If it was high in the first one, say intermediate at the second one, it dropped a little bit further, and so on. So both in terms of improvement and worsening, that serial measurement helps you to guide your prognostication and really home in on individuals. So that's quite useful because a lot of the time we worry that FIB4 might miss people. And I think one of the really important things here is that if you build it into your standard care and plan to come back, say in 12 months or 2 years later and retest, the likelihood of people coming to harm in that window is relatively modest. So that's a useful and tractable tool.
So I think that's really important point you just made, which is even if the value is below the 1.3 threshold, because of the very low actual risk of an event, you can come back and retest in a year's time. And so that gives you multiple shots at goal, if you will.
Absolutely.
Yeah. Well, coming back to the patients who have higher FIB4s. So there, I think maybe we can talk a little bit about secondary testing. And the two tests, that we tend to use a lot is the vibration control transient elastography, and the other one is a blood-based test called the enhanced liver fibrosis test. So maybe I'll ask both of you the same question. Which one is your first go-to, and when would you use the other one? So Richard, do you want to take it first, and then we'll ask Quentin if he agrees with you?
So I think your strategy of what you're going to do for your next test, if you have a patient who has an increased FIB4 where they might have liver disease, really depends on the availability that you have in your practice setting. And so for us at Virginia Commonwealth University, our next test that we would do would be some sort of transient elastography, either the VCTE that Arun had talked about, or one of the other modalities, including point shear wave elastography, which are fairly equivalent. Depending on the way your machine is set up, you'll basically get the same number. And for us, the advantage of doing that is that we can do it right there in the office, so the patient gets an immediate result. And it's a visual that patients can see, and everybody sort of likes to see that report. And both the point shear wave as well as the VCTE method also can let me know how much fat or steatosis is in the liver based on whether it's the CAP score or the whatever equivalent modality that your scanner has. And if you don't have that sort of in-office testing, you can either refer the patient to someone who has it, or often many radiology practices now can do that if your practice doesn't have the volume to have your own instrument. So that's our next test that we would do in almost all of our patients, and only go to something like the enhanced liver fibrosis or ELF test if for some reason we can't get a reading, because sometimes it's hard to, based on the patient's body habitus, or if the VCTE or the elastography is really discordant from the FIB4 or something else, and we're not sure which one to believe, then we'll usually order the other test as kind of the tiebreaker.
So Quentin, is that your sort of how you use it as well?
Yeah, it is. I mean, so obviously the guidelines both in the United States and in Europe recommend one or other of those, so either the ELF test or VCTE. In my head, I actually view them as complementary. So elastography, it's measuring a physical property of the liver, and I think that's quite useful. Whereas ELF, it's actually speaking to that extracellular matrix turnover, so it's pinpointing some of the biology. As it happens, exactly as Richard says, you've got to use the one the hospital's prepared to let you have. And in my case, we use VCTE. So that's the next line test in our practice as well.
Although I think it's important to point out that VCT is an approved instrument as an aid to management of patients with liver disease. It is not specifically approved for a specific stage of fibrosis, whereas the ELF test is also approved and has regulatory clearance as a prognostic biomarker. So this brings us to the really important issue of.
And Arun, I would add, it's also NICE approved in the UK for ELF, so that's really important.
Exactly. And so for those who do not have access to a VCTE, this is really a very viable and important alternative that also gives us prognostic information. And the ELF test is the only biomarker currently that actually has that regulatory approval. So maybe, Richard, you just authored the non-invasive test document from the ASLD. Speak to us a little bit about the cutoffs of VCT and ELF and how we can standardize this so that we're not using different cutoffs that don't line up with each other in terms of their ability to either predict fibrosis or predict clinical risk.
So thanks, Arun. So I think like the FIB4 patients with a low VCTE, for example, something below 5, have a very good negative predictive value for the presence of advanced fibrosis. And so that would be sort of the lower, cutoff and equivalent. But it's also important to remember that if you repeat the VCTE on the same person on the same day, or bring them back a week later, or you may get a value that could be 25% different. And so it's really not an absolute number. So if I get a number, for example, that's 7 kilopascals, that true number may be anywhere between 5 or it could be 9. And so it's important to realize that there are some ranges around it. And so for us, if it's less than 5, we're pretty confident that that patient doesn't have any liver disease, and we would sort of classify that patient according to the guidelines as F0 to F1, as opposed to someone who might have a score of 12 or 14. That patient is much more likely to have either F3 or F4 fibrosis. And we use these thresholds to identify those for MASH treatment. And that I know is going to be covered in a different webinar, but the current recommendations are to think about MASH treatment if the stiffness of at least 8, and some guidelines recommend 10 as a number where you're unlikely to miss people. If you use 8 as the threshold, the true number may be 6. And so you may be over-treating some, but it kind of really depends on what else you think is going with the patient. So less than 5 is definitely F0 to F1. Probably greater than 15 is definitely probably in the cirrhosis range. And then you have sort of that area that is probably 8 to 12 is the F2 to 3s that we would target for therapy.
Good. So very quickly, Quentin, then, a lot of the original guidances set the lower threshold for ELF to be 7.7, would be the equivalent of this 8 kilopascals for the transient elastography. Do you agree with that?
That's excuse me, that's a interesting question. In my head, I tend to focus in on the 9.8 threshold. I find it a more tractable threshold to actually use. So that would be the number I keep in my head, Arun.
Yeah, I think there is some of the older literature may have a little bit of discordance with the cutoffs, because I think in terms of identifying those who have clinically significant fibrosis, that's enough fibrosis to put you at a little increased risk of having a liver outcome. A cutoff of 9 is emerging as the more appropriate cutoff and would be similar to this range of 8 to 10 kilopascals for the VCTE, whereas for the higher risk, which historically meant that you might have cirrhosis, a cutoff was 12 kilopascals for VCTE was used, and this was considered equivalent to about a 9.8 for the ELF. But I think probably the cutoff for cirrhosis is maybe, depending on whether you're looking at high sensitivity cutoff or high specificity cutoffs, maybe a little bit different. But I think the key numbers to remember really are if your liver stiffness is below 10 or your ELF is below 9, you're at a very low risk. And if your ELF is 9.8 or higher, or your liver stiffness is above 10 to 12 range, then you certainly should consider these patients for therapy. Of course, there's a high cutoff of 11.3 for ELF, which is involved where patients are very close to a clinical outcome, likely to have a portal hypertension. And similarly with liver stiffness, if the value is above 25, or if a value is over 15 with thrombocytopenia, that might identify the same population. So with that, I think this really highlights the need to keep these cutoffs in mind as we think about secondary assessment of patients with MASL, starting with the FIB4, wrapping up with either a VCTE or an ELF, so that we can identify those most at risk. And I refer you once again to the webinar that we had with Medscape that goes through all of the science and all of the numbers that led to this conversation. And we look forward to having you visit us over there as well. Thank you.
Cut.
So